All right, folks, this meeting is called to order. Good morning and welcome. Today is our first regular board meeting since the retreat. Our meetings will be hybrid going forward. Healthcare Authority staff will be on site. The board members and other attendees have the option of attending on site or via Zoom. For our Zoom attendees, our opening slide has information about how attendees can turn on closed captioning subtitles. Let's go with board member introductions. Myra Johnson. I heard it. It was pretty faint. Myra, let's do another test again.
Good morning. Was that better? I can turn my volume up.
That's better. You're good to go. Donna Hanson-Murray.
Good morning.
Morning, Donna. Amy Griffin. Amy Griffin.
I'm here. Sorry, had troubles unmuting.
That's okay. Allison Polson. We know you're here.
with 2.5 more inches of snow.
Oh, wow.
Here in Spokane, I'm afraid we will never see grass again.
What's your total this year?
Oh gosh, I think it's something like 147 days with snow on the ground.
I think we can all agree that's.
But I would say there's at least 2 feet still piled up in where we had to plow.
I think we can all agree that's a lot. Okay.
That's a lot.
Yeah. We got Terry House.
Good morning.
Morning, Terry. Pamela Cruz.
Good morning.
Morning, Pamela. And Carrie Schaefer.
Good morning.
And Carrie has joined us in person. She was like, I want to get into some traffic, into some wet roads, and I'm going to make it, and wind. And she did. And we have Katie Hatfield from the AGO.
Hello, everybody.
Hey, Katie. And I'm Lou McDermott, the chair of the SEBB board and the deputy director for the Healthcare Authority. With board members both in person and virtually, it would be helpful for board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are questions. Board members attending virtually will also be watching in case you use your Zoom hand and to indicate that you have a question. The public will have an opportunity to provide general comments at the end of the meeting during the public comment period. Dave's going to give us an overview of today's agenda.
Good morning, Chair McDermott, members of the board. Dave Eisminger here. We have a relatively short agenda for today, and it suddenly, unfortunately, got shorter this morning because we have a staff member who had a family emergency, and so we're going to end up delaying a presentation. But we're going to start off with a bylaws amendment that was proposed at the last meeting and ask the board to consider taking action on that, and it relates to the public comment processes that have historically been used with the board, but kind of codifying that practice within the bylaws. And then we'll have an update from Kate Walker about the bills that are in the legislative process. We like our staff to be here as much as possible, but sometimes health gets in the way, so he will be remote. Then the presentation that we're going to delay is the SEB program financial overview. Again, just a staff member family emergency that it'll be best, and it's not mission critical, requiring some sort of action or will have a cascading effect on the board season. So we'll just plan to have that in April. But we will have Stella here to do the introduction of policy resolutions. We will have her introduce some eligibility enrollment policies. This will be the introductory phase as a reminder for everyone, especially people in the public who might be attending the SEB board for the first time. In both the SEB and PEB boards, there's this very strong tradition and process of introducing a resolution at one meeting, having a stakeholder process before the next meeting, and then bringing that resolution back with feedback and any modifications for potential action at the next meeting. So we're at the introductory phase for these eligibility and enrollment policies. And then we're going to have a presentation from our financial team about hearing instruments, and then we'll have public comment and end the day. Oh, I do want to say for those in the building that if we have an emergency, that we all go out to the left to the parking lot that I'm pointing to. Everyone in the virtual world doesn't need to go there, so they don't need to see where I'm pointing. And if you need the restroom, it's down the hall to the right.
All right. Any questions from board members? Let's get going. Our first agenda item, January retreat follow-up. Dave's going to give us an update. Tab number 3. His materials behind tab number 3, and there's some details, some questions that were asked during the retreat, and you've got some responses to that.
Yes, I always, good morning everyone again. I always do some cleanup for things that don't quite rise to the level of another full presentation but don't quite fit anywhere else. So I have that, I take on that responsibility for the follow-up. The first topic that we have on slide 2 is about mail order pharmacy utilization. And there were some questions as we move on to slide 3 in particular about as mail order pharmacies are being more heavily utilized, and many of you have likely heard and will continue to hear a little bit more this board season, and I anticipate public comment in future board meetings and some additional questions about this, about the mail order pharmacy process. Kaiser Washington in particular transitioned to their first fill program. We talked about that with the board last season as part of their change in benefit design going into the 2023 plan year. But so I anticipate there may be more questions, but the specific question I have to bring back to you today relates to what type of data we have about adverse outcomes like lost mail, stolen mail, late deliveries, and those types of impacts, or overall decreased utilization. And so the answer on slide 4 that I have for you is that going by carrier, Kaiser Permanente doesn't report evidence of any increased adverse outcomes. They're reporting over 90% customer service satisfaction within the Northwest region. A reminder, the Northwest region is confusingly in Southwest Washington. That's Clark and Cowlitz County. And then that 97% of prescriptions were delivered within 2 days in the Kaiser Washington. And that's the predominant rest of the state service area that Kaiser has in the SEB portfolio.
Quick question on that 90%. Is that 90% related to the mail order component of their pharmacy or all their pharmacy stuff?
I believe it's the mail order pharmacy.
Do we have the number for the other stuff, the in-person? It would just be interesting to see how people feel about the in-person versus the mail order.
We will follow up as the follow-up.
Appreciate it.
For Primera, they're not seeing anything that they're reporting the consistent application and utilization of mail order pharmacy as has had in the past. And within the Uniform Medical Plan, we're also seeing no evidence that there's adverse outcomes with mail order. There's minimal to zero complaints that have been related to mail order pharmacy use in 2022. And so I did want to bring back from Luke a little bit more information about why he had presented on slide 5 that there was decreased utilization in 2022 so far. There were a couple of data points that he thought would be helpful for the board to know. The first was in that data he was sharing, it was incomplete because it only went through September. So there's the claims run out period that is still kind of underway. So the full data only went through September. So we weren't quite comparing apples to apples in the year-over-year comparisons. And then it's possible, we all know that the SEB program launched about 30 days before the first cases of COVID in our state. And so, there's still just kind of some of these questions about how members are really engaging in what is, for us, a 3-4 year system, but there's never been any sense of normalcy for how they interact with health, with obtaining services, whether it's pharmaceutical or medical. And so it's possible that people are just interested in returning to retail pharmacies as they're part of their transition back to a more normal pre-COVID way of living in life. The last piece is that the SEB program does appear to be mirroring the PEB program's utilization, and we think that that's really just related to the plan design is so similar. So that is about the pharmacy pieces that I have today. Again, I don't anticipate that this will be the end of conversation on mail order pharmacy, but I want to see if there's any follow-up questions before I transition to vision follow-up.
Any questions from the board? Any hands up? No.
All right. So then the next set of follow-up is related to vision care, lens enhancements, and pediatric vision coverage. And so there's a series of slides in here, and I'm not going to go through them in full detail, but wanted to provide you with those comparison charts. There was a question about, just a reminder about the different levels of coverage in the SEB standalone vision plans for all the components that are add-ons or enhancements that many of our members are accessing for the lens part of the benefit. So this first chart has those member co-payments that are related and cost shares. The second part of the question on slide 8 was related to whether board member might remember that there was a question about is is the pediatric vision benefit an annual benefit or every 2-year benefit? And we were pretty sure in real time in the retreat that the answer was 1 year, and it indeed is an annual benefit for pediatric vision, and it's been that way since the launch of the SEB program. So for eyeglasses, there's that standard frame plus lenses at 100%, or a year's supply of contact lenses. And so for our benefit for people who are under 19, that is an annual benefit. So I wanted just to reassure the board about that. And then the subsequent slides, again, I'm not going to go through those in vast detail, but wanted to provide you with the comparison charts on the benefit design of the various aspects of pediatric coverage that are happening on an annual basis. So we have eye exams, frames, lenses, and the same lens enhancements as it relates to our pediatric setting. And those are the follow-ups that I had for the board in the retreat.
Any additional questions from the board? Seeing none, thank you. And Dave's going to go over the bylaw amendment, and it's going to be, he's going to present a vote on clarifying our bylaws regarding public testimony. Materials behind tab number 4.
All right. I'm going to keep saying good morning. So good morning, everyone, again. As we go to slide number 3, this is the only slide in the slide deck, really. This is the exact slide that was brought to the board at the last meeting. It's just the subset of the bylaws where an actual amendment is proposed, the new language being highlighted in red and the removed language being stricken through on the slide. The full bylaws are always included at the front of the briefing book, so you can see in context the entirety of the bylaws for every meeting. This proposal, again, is specific to public testimony. This was driven by a request by a PEB board member, and many people actually believe that this was already in the bylaws. It's a very long-standing practice for how PEB board meetings had been run, and from the beginning of the SEB board, a similar process. And this is really just clarifying that there will always be an opportunity for public comment before a vote is taken on any resolution. And so, there are multiple times for public comment that have been held during these board meetings. There is a general public comment that is always scheduled at the end of the board meeting, but anytime there's something brought to the board for action as part of that resolution process, once it is moved and seconded and there's debate going on, the chair has always called for comment from the public specific to the resolution that's about to be voted on. And that is essentially what this language is doing, is codifying in your bylaws that is exactly what will happen, and also being very clear that the chair also has discretion to allow public comment at other points of the meeting if there's that desire or need should arise. I haven't heard any concerns about this proposal from either board or any stakeholders that attend our meetings, and so I would just bring this to you for action. And I apologize, Chair, that we did not write into the annotated agenda the voting process.
That's okay. Are we going to be doing a roll call vote?
That would be great, and I think it would be helpful, Katie, to clarify the threshold that is required for passing a bylaw amendment.
Yes, I was just looking that
You're
up,
on.
actually. I'm on. So unlike regular resolutions, bylaws need to, in order to be amended, need to be approved by 2/3 majority vote of the board.
Okay.
So I think that we have 8 members, so we need 6 yeses.
We'll do the math if we don't have a
Okay.
unanimous. All right, I will kind of do this from memory, but do I have a motion to amend the policy as written?
I so move.
Excellent. Do
This is Myra Johnson.
Thank you, Myra. Do I have a second?
Andrew, second.
Oh, we have a second. Any comments from the board? Any comments from the public? Fred? Fred, you're on, sir.
Good morning.
Good morning, Fred.
I'm pleased to see that the second part that is proposed is that the discretion of the chair, opportunities for public testimony may be made available at other times during the board meeting. I find it kind of hard to remember my questions as particularly long meetings go on, and then to wait till the very end of the meeting to kind of cover, it could be as many as 4 or 5 different areas that you touched on during the meeting. So, I mean, ideally, and I can understand the need to kind of manage the meeting, ideally it'd be nice to take questions after each tab section from the public. That would be my ideal arrangement, but at least this allows the opportunity. Thank you.
Thank you, Fred. Any other comments? All right. Any last comments from the board? We'll go ahead and do a roll call vote, starting with Myra.
Aye.
Donna Hanson-Murray,
Yes.
Amy Griffin,
Yes.
Allison Poulsen,
Yes.
Terry House,
Sorry, yes.
Pamela Cruz,
Yes.
Carrie Schaefer,
Yes.
and Lou McDermott, yes. No math is necessary. The amendment passes as written. All right. Our next item is the legislative update from Cade Walker, Policy Rules and Compliance Section Manager in the IRB Division, and he's going to share updates on what's going on with bills in our legislative season for 2023. Cade's materials behind tab number 5. Cade, how you doing, sir?
Doing all right, sir. How are you doing, Chair?
Doing well.
Well, thank you, Chair, and members of the board. Again, Cade Walker here to provide you with another exhilarating update of our legislative process that we are currently going through. Thank you to the sound guy and everything else. So I'm going to start with the slide that kind of goes through how busy we've been so far. As you can see, we've had a good number of bills that we've processed. This is a couple of weeks old already. We've already added another handful of bills that we've been working on. We've had I would say so far this year, we've had a good number, probably more than the normal number of high priority bills that HC or the ERB, the division that does the PEB and SEB programs, has been the lead analyst on for the agency. So we've seen a lot of high priority bills come our way. We've also seen a pretty significant number of fiscal notes this year, which does make some sense. It is the start of the 2-year term for the legislature, and so this is the long session where more of the budget setting is done, and so it would make sense that there's a lot more interest in what's going on in the fiscal realm, the fiscal impacts of legislation. But more information on fiscal updates will come a little later, but I know that the budgets are going to be released in probably about another month or so. So there'll be more information on the budgets and process in time to follow, in meetings to follow. Next slide, please. Here's just our topical funnel to show you how a bill becomes a bill process, how a bill becomes law process. And this is just us tracking those high priority bills that ERB is the lead analyst on for the agency. You can see quite a bit of movement in that process. In fact, the majority of the bills that were sitting, those 10 bills that were in the fiscal chamber, all but one of those have moved on to the floor or moved on to the opposite chamber. And so it's been there's been quite a bit of movement on the legislation that we are tracking closely as it moves through the process of becoming a law. Next slide, please. Just some quick updates on a bit of the legislation that is coming out of the agency. Again, Senate Bill 5700 is agency request legislation that is primarily as far as the PEB and SEB program. So it is a cleanup bill in the statutes that we have after the creation of the SEB program and different agencies or portions of agencies being consolidated into the Healthcare Authority. This legislation is just cleaning up language in the statutes. It has no policy impacts except for a little bit of minor things on the Drug Affordability Board that don't actually impact our programs. Then we have Senate Bill 5421. This is the language that we have drafted in order to create a new public records exemption for any of the data or information collected as part of the enrollment process for the PEB and SEB programs. We feel this is a needed protection to ensure, it's a belt and suspenders type of protection to make sure that the data that we collect as part of the enrollment process for PEB and SEB and any administrative information that we collect is exempt from disclosure under the Public Records Act. This will create some other opportunities for us to expand the information that we collect, including race, ethnicity, and language data at some point, which we will have the conversation in the future for us to consider collecting that information and being able to do further analytics to support equity and health equity in our populations. But this legislation is an important first step to ensuring that information that we could collect in the future is protected from any disclosure requests that would come in. Next slide, please. Let's get into some of the topical pieces of legislation. All of these that are crossed out are bills that have not made it past the cutoff. And I think there's only one other bill that didn't make it past the fiscal cutoff that was last Friday, and I'll mention that when we get to that bill. But as far as the SEB specific legislation goes, there's the Senate Bill 5275, SEB Benefits Access. This is creating the employer group like structure that exists in PEB, but for the SEB program, which would allow for tribal schools, the organizations representing labor unions, or the organizations representing employees, and school board members to participate on a voluntary basis in the SEB program. This is something that is currently done in the PEB program for what we refer to as employer groups, which include other types of entities like cities, municipalities, tribal schools, if they're part of tribal government, would be able to participate under the PEB program, but now they'll have the ability to participate in SEB, even if they're not part of the tribal government. And so we're continuing to track that, and we'll see that where that legislation continues. On the retiree side, maybe not as pertinent to the board, but certainly interesting because the members in SEB eventually will go on to have PEB retiree coverage. There's House Bill 1008, which is expanding the definition of separated employee to include Plan 2 members of the retirement system. What this will allow for is for the Plan 2 members who separate from state service prior to being Medicare eligible and allow them to enroll in retiree coverage subject to certain requirements before they're otherwise Medicare eligible, which is something that is currently allowed for Plan 3 members, and this is just expanding that definition of separated employee, which is what we use in that eligibility determination, to now include Plan 2 members so that they can have retiree benefits earlier should they separate prior to 65. And there's also the Senate Bill 5490. This is a second bite at the apple for retirees who had failed to submit a deferral form when they separated from state employment, and therefore they were unable to come back to, or they were ineligible for retiree coverage. This creates a fairly narrow opportunity for the population that had been denied retiree coverage because they failed to do that deferral form and had submitted an appeal as of the end of last year. If they had done that, then they would be allowed a second bite at the apple of coming into retiree coverage. And so we're tracking that. We've seen the amendment on that and provided some date clarification. So we're tracking that. I think that one's actually removed to, I think it's on the floor for debate. Then we have House Bill 1804 and its companion bill, Senate Bill 5696. This is pertaining to those employer groups that I was mentioning earlier with regards to 5275. But for employer groups in the PEB program that join and then leave, it allows their retirees to remain in the PEB retiree coverage, and any of the retirees that lost coverage when their employer group left to also be retained. And this is just working to fix an issue that was identified. It was some retirees that were left kind of in the lurch afterwards. So just resolving an issue for a fairly relatively small population of former retirees. Next slide, please. Excuse me. So we have our bills on medical services cost sharing, where the legislature is seeking to reduce the cost sharing for individuals or eliminate it entirely. And so all four of these concepts of these medical cost sharings being reduced or eliminated are still moving through the process, are either on the floor of the originating chamber or have switched chambers now. So that includes the abortion cost sharing, fertility service coverages, hearing instrument coverages, and breast examination cost sharing. Next slide, please. Here's some of the bills that we're tracking with regards to pharmacy. We have 5213 regarding the regulation of pharmacy benefit managers that we're tracking. There's the House Bill 1269, which is expanding some of the teeth, as it were, in the drug affordability board that is part of that's housed within the healthcare authority. And then Senate Bill 5729, expanding the $35 cap in insulin cost sharing, the insulin cost sharing cap, and expanding that $35 cap for another year or so. I do want to note that the prescription cost sharing bill, HB 1465, 54, 45, that did not make it out of the policy committee, as well as the no cost sharing for insulin for anyone under the age of 21. House Bill 1725 did not make it out of the policy committee as well. Next slide, please. The last few kind of the wrap up of the different less specific topical areas. There's still a lot of expanded licensures and new licensure bills that are working their way through the process. We're tracking those to an extent because of the potential impact in the future it may have on our programs. These don't necessarily require immediate changes to our plans. Some of the expanded licensures will have some impact on our plans. The new licensures won't necessarily have any impacts on our plans until there's a requirement for them to be covered services. That would include things like the lactation consultants or music therapists that unless there's a requirement for them to be covered, those new licensures won't have an impact on our plans at this point. I did note that recently that on Friday, the Senate Bill 5373 regarding the parity and reimbursement payments for ARNPs and PAs did not make it out of the fiscal committee. So that legislation is currently dead until it may come back next session, which is a continuation of this session. So next year we may see it again, but it is currently not moving forward again, not moving forward this session. There's some of Dave's favorite legislation this year regarding the pet insurance regulation. Both House Bill 1208 and 5319 have moved forward. I believe 5319 is actually already in the House Policy Committee for review and public hearing. So that's just allowing for the Office of Insurance Commissioner to regulate pet insurance, which is a first step that would be necessary for the SEBB board, which has authority in statute already to have the program study and provide recommendations and consider providing pet insurance as a as an optional benefit for employees in the SEBB program. So that's the first step, would be having that regulated by the Office of Insurance Commissioner. So both those bills are continuing through the process. And last but not least is a rather tricky and a much talked about bill, House Bill 1357, which is modernizing the prior authorizations process. I think it's a rather ambitious bill. The agency has provided a lot of feedback and working a lot with the sponsors and advocates for that legislation and looking at how the entire market, the entire Washington State market handles its prior authorizations, creating a little bit more of a structure that will be, I think, they're attempting to have more transparency with it and better oversight from the Office of the Insurance Commissioner. This would have impacts on all of our fully insured carriers, and we believe it would also have impacts on our self-insured plan, the UMP plan. We're continuing to provide feedback to the legislature about those impacts and whether that's what they're intended or not, based on the language in the bill. With that, that's I think a pretty quick whirlwind. I'll be happy to take any questions that the board may have about legislation.
Any questions for Kate?
There is one piece of context I thought that I could give as well. If we could go back to slide 6, just wanted to give people, the board, a sense of some of the extent of the cost of these various bills. So these are all about shifting or cost shares or changing benefit design. So if you just look at the first and the last one, each of those, abortion cost sharing and then the two breast exam bills, are estimated in its totality to shift cost of about $1 million if you add both of those or all three of those bills together, just for the SEB program. And it's a little bit higher in the PEB program, but overall it's about $1 million of cost sharing that would be shifted into the plan for the Uniform Medical Plan specifically, related to that first, the abortion cost sharing and the breast exam cost sharing bills. The fertility service coverage bill would be a new benefit within the Uniform Medical Plan. There is minimal coverage related to fertility services currently in UMP, or in fact many of the benefits, medical benefits within the program. But the fiscal note for that is indeterminate at this point, because there is a study that is being done with Milliman that is due at the end of this fiscal year in June, that goes through a lot of permutations on potential fertility benefits. And so there would definitely be cost related to this benefit as a brand new benefit within the plan, but it is indeterminate at this point. And then for hearing instrument coverage, we'll be talking about hearing instruments for a couple of meetings now, but this bill, just to set this piece up a little bit, is our current benefit design across the portfolio is a hearing aid per ear at no cost every 5 years. So per ear, every 5 years, no cost. And this bill sets it at every 3 years, a benefit per ear of at least $3,000. So there's a couple of moving parts there. And as I said, that is the version of the bill as it stands today that was voted out of the House. Again, the House for that version is every 3 years per ear, a benefit of at least $3,000. So we're gonna we were planning and bringing data about hearing instruments this board season anyway. This bill is tracking along the process, but just wanted to give people some context, a little bit more context about those bills.
Any follow-up questions from the board for Dave or Kate? We see anything? Nope. Well, our next agenda item was the SEB program financial overview, and Tanya and Molly were going to do that. And for those who missed Dave's opening, we had a staff member is having an issue and is unable to make today's meeting, so we've decided to calendar this until April. So we'll be doing that. We do have a 5-minute break schedule, but I think we're going to go ahead, unless the board objects, I think we're going to go on to the next agenda item, and then we will take our 5-minute break. Everybody good with that? All right. Next agenda item, Rules and Policy Development. Stella Ng, Policy Rules Coordinator in the ERB Division, is here to introduce some policy resolutions. As a reminder, because these are the first resolutions for this board season, no action will be requested on these today, and they're being introduced for initial discussion and feedback. Materials are behind tab number 7. Stella, are you with us? And slides are up. We're getting there.
We're skipping the previous presentation from the first.
Oh, I see. I
For a
see.
second.
Yes.
She's having audio issues.
Stella, if you're unable to, this is Zoom, right? If you're unable to connect through Zoom, there is a dial-in. There is a dial-in, right?
I think she might also be.
Oh, she's here.
Here on her way. Yes.
Oh.
Maybe we can take our 5 minutes.
Maybe we should.
Why don't we take our 5-minute break? We'll track down Stella. She might be in the lunchroom having a little snack. So now I'm getting it. The signals from people are telling me. Yes. Okay. We're gonna go ahead and take a 5-minute break. It is 9:36. Well, let's make it a little longer. We'll come back at 9:45. That'll give us a little time. Thank you, everyone. Fair enough. All right, I think we're going to get rolling again. And our next presentation, Rules and Policy Development, Stella Ng. Policy and Rules Coordinator in the ERB Division is here to introduce some policy resolutions. As a reminder, because these are first resolutions for this board season, no action will be requested on these today, and they're being introduced for initial discussion. Materials behind tab number 7. And Stella, welcome. Sorry, it was a little fire drill. We made some changes to the agenda and we didn't tell you. And that's okay. That happens.
Good morning, Chair McDermott, members of the board. My name is Stella Ng, and I'm the Policy and Rules Coordinator for the UP Division. Today, I have 4 proposed policy resolutions to introduce. Next slide, please. This slide and the next slides are included in the presentation, so you will have them available as you consider the policies we will discuss. Slide 4. Here are the 4 proposed resolutions being introduced. The first 3 resolutions address continuation coverage for non-represented educational service district school employees and their dependents. The last resolution addresses situations when subscribers do not live or work in the plan's service area and do not make a planned election within their required period. Slide 6. Thank you. For background information, I've included engrossed substitute House Bill 2140 regarding education funding for K-12 passed by the legislature in the 2019 legislative session. This session law requires all employees of educational service districts, including non-represented employees, to participate in the SEB program beginning January 1st, 2024. The first 3 proposed resolutions address continuation coverage for the non-represented employees of the ESDs and their dependents, which will align to how we transitioned school employees from their school district's coverage to the SEB program in 2020. I have placed resolutions SEB 2018-58, SEB 2019-06, and SEB 2019-07 in the appendix for your reference. Next slide, please.
Real quick, this is Dave. Just want to remind everybody, when the SEB program launched, it began with, for educational service districts, they were the one exception to kind of mandatory participation in the SEB program. All school districts with both represented and non-represented employees and charter schools had complete participation required in the SEB program on January 1 of 2020. ESDs had required participation for their subset of represented employees, but their non-represented employees were put on this path for participation as of January of 2024. As time has gone by in the past couple of years, most of the ESD non-represented employees are actually in the PEB program today. And so we will generally be transitioning them from the PEB risk pools to the SEB risk pools at the end of this year, and that this is just kind of the culmination of the rules that are necessary to effectuate that transfer. So just wanted that additional context.
Thank you, Dave. Here's the first policy proposal. Proposed Resolution SEB 2023-01 addresses SEB continuation coverage eligibility for non-represented ESD school employees who will not be eligible for SEB benefits under the SEB program. This proposed resolution is brought to the board because this provides eligibility to school employees and the dependents who will not meet the SEB eligibility criteria as of January 1st, 2024. A change in eligibility other than a termination or reduction in hours is not considered as a COBRA qualifying event. This is more generous eligibility than required by federal statute, and the board passed Resolution SEB 2019-06 to address this similar situation at the time. And it reads, Proposed Resolution SEB 2023-01, SEB continuation coverage eligibility for non-represented ESD school employees not eligible for benefits under the SEB program. A non-represented educational service district school employee and the dependents who are enrolled in medical, dental, or vision under a group plan offered by a SEB organization on December 31st, 2023, who lose eligibility because the school employee is not eligible under the SEB program, may elect to enroll in one or more of the following SEB benefits: medical, dental, or vision coverage. These benefits will be provided for a maximum of 18 months on a self-pay basis.
Dave here again. There's 2 terms that I think are just helpful to give, Connie's going to hate the word context, give context on. That's my new word for the year. The first is SEB organization. It's capitalized in this resolution because it's a defined term, and that phrase is the umbrella term used for educational service districts, school districts, charter schools. And so just wanted to highlight for people what that word means and its capitalization. The other is continuation coverage. Stella here described that this eligibility is more generous that's required under federal law. We use that phrase here at HCA and in the PEB and SEB programs, continuation coverage, as again an umbrella term for a couple of different ways in which eligibility is offered. It includes COBRA coverage, but it also includes other coverage extensions like this that are being proposed. So that's a term that is not necessarily used a lot of other places, but that is an overarching term that includes both COBRA and other eligibility like this.
Next slide, please. The second proposed resolution, SEB 2023-02, addresses SEB continuation coverage for dependents who are not eligible under the SEB program. Currently, 8 out of 9 ESDs are participating in the PEP program, except for ESD 121. Although all 9 ESDs reported they are using the same dependent eligibility criteria as the SEB program for the dependents of non-represented ESD employees. In the event a dependent loses eligibility on December 31st, 2023, because they aren't considered as an eligible dependent under the SEB program, this proposed policy resolution would allow them to elect continuation coverage for a maximum of 36 months on a self-pay basis. The board passed resolution SEB 2018-58 to address this same situation at the time, and it reads, Proposed Resolution SEB 2023-02, SEB continuation coverage for dependents not eligible under the SEB program. A dependent of a SEB-eligible, non-represented school employee of an educational service district who is enrolled in medical, dental, or vision under a school employee's account on December 31st, 2023, who loses eligibility because they are not an eligible dependent under the SEB program may enroll in medical, dental, and vision for a maximum of 36 months on a self-paid basis. Next slide, please. The third proposed resolution, SEB 2023-03, is similar to proposed resolution SEB 2023-02, except that these dependents are already on some type of continuation coverage through the ESDs on December 31st, 2023, who aren't considered to be eligible under COBRA. Policy Resolution SEB 2019-07 was passed by the board to address this similar situation. For example, a dependent child who has reached age 26 in August 2023 and in September 2023 starts continuation coverage and is still on the ESD continuation coverage on December 31st, 2023, will be allowed to finish out their remaining months up to the maximum number of months authorized by COBRA for a similar event. COBRA would allow 36 months for this qualifying event, so this dependent has already used 4 months, from September to December, and they'd be allowed to have 32 more months of coverage based on this proposed resolution. And it reads, Proposed Resolution SEB 2023-03, SEB continuation coverage for a non-represented school employee's dependent who is already on an ESD's continuation coverage. A dependent of a non-represented school employee who is continuing medical, dental, or vision through an educational service district on December 31st, 2023, may elect to finish out their remaining months up to the maximum number of months authorized by COBRA for a similar event by enrolling in a medical, dental, or vision plan offered through the SEB program on a self-paid basis. And we have a last resolution on the next slide. The last proposed resolution, SEB 2023-04, addresses when a subscriber has a change in residence or employment location and do not make a plan change when the medical plan is no longer available either where they live or where they work. This proposed resolution allows HCA to disenroll the subscriber and their dependents from their current medical plan and enroll them in a medical plan as selected by HCA. Under state law, an enrollee must live or work in the plan's service area. SEB's current rule already allow a SEB subscriber who has a change in residence or employment location that affects health plan availability to switch plans. We need to update our rules to require a subscriber to change medical plans if the medical plan they are enrolled in is no longer available based on either a change in residence or a change in employment location. And it reads, Proposed Resolution SEB 2023-04, when a subscriber has a change in residence or employment location that affects medical plan availability. After a change in residence or employment location, the subscriber must elect a new medical plan if a subscriber's current medical plan is no longer available based on either residence or employment location. If they do not elect a new medical plan within the time period allowed by special open enrollment rules, the subscriber will be enrolled in a SEB medical plan as designated by the director or designee. And we have a few examples to illustrate this policy proposal. Example number 1. Sarah lives in Clark County, is an employee of Stevenson-Carson School District in Skamania County. Sarah enrolled in Kaiser Permanente Northwest 1. In February 2024, Sarah moves her residence from Clark County to Skamania County. Because Sarah no longer lives or works in a county where Kaiser Permanente Northwest 1 is available, under current rules, Sarah must elect a new medical plan. What happens if Sarah fails to elect a new medical plan during the special open enrollment period when her current Kaiser Permanente Northwest 1 is no longer available in the county where she lives or works? If Sarah does not elect a new medical plan within the time period allowed by special open enrollment rules, she will be enrolled in a SEB medical plan as designated by the director or designee.
I don't have any questions.
Okay.
I'm just watching you do your presentation.
Well, this is-
You seem very curious, so I was wondering if you have a question or not.
But this is Dave. I just want to state a couple of things just to be clear for folks that Kaiser Permanente Northwest is offered only its service area is Cowlitz and Clark County. So just wanted to remind people of that. Stevenson-Carson School District is wholly within Skamania County. It is not a school district that straddles county lines. And in this type of instance in Skamania County, the plan offerings that are available that would be options for the designation by the director or the designee would be UMP or Primera. And in that type of instance, the most likely scenario is the general automatic enrollment plan UMP Achieve 2. It's going to vary depending on circumstances, and we'll get into some of those with the other examples, but I just want to kind of illustrate what the most likely outcome is. And the reason that the policy resolution leaves it open-ended as to which plan is because it will vary a little bit based on circumstances. But in this type of scenario where somebody is living and working within Skamania County, we would go to the typical automatic enrollment plan that was discussed during the program launch, which is Achieve.
Anyone?
The automatic enrollment plan is Achieve 1.
Achieve 1. John, is that correct? He's given the nod. Yes,
Okay.
Achieve 1.
Yes, it is Achieve 1, yes.
And used illustrate and not context. So we're moving forward.
We're moving forward. Got my thesaurus.
Second example. Next slide, please. Thank you. Kelly lives in Clark County as an employee of the Vancouver School District in Clark County. Kelly enrolled in Kaiser Permanente Northwest 2. In February 2024, Kelly moves her residence from Clark County to Skamania County but does not change her employment. Can Kelly remain in Kaiser Permanente Northwest 2 if she has a change in her residence? While Kelly has the option to elect a new medical plan under the special open enrollment rules, if Kelly does not elect to change plans, she will remain enrolled in Kaiser Permanente Northwest 2 because she still works in Clark County. Next example, please. Example 3. Jose lives in Skamania County and is an employee of the Vancouver School District in Clark County. Jose enrolled in Kaiser Permanente Northwest 1. In March 2024, Jose leaves his job at the Vancouver School District and starts a new job at the Stevenson Carson School District in Skamania County. What happens if Jose fails to elect a new medical plan during the special open enrollment period when his current Kaiser Permanente Northwest 1 is no longer available in the county he lives or works? If Jose does not elect a new medical plan within the time period allowed by special open enrollment rules, he will be enrolled in a SEBB medical plan as designated by the director or designee. And we have the last example for this resolution. Example number 4. Mike lives in Clark County, is an employee of the Vancouver School District in Clark County. Mike enrolled in Kaiser Permanente Northwest 1. In April 2024, Mike leaves his job at the Vancouver School District and start a new job at the Stevenson Carson School District in Skamania County, but does not change his residence. Can Mike remain in Kaiser Permanente Northwest 1 if he has a change in employment? While Mike has the option to elect a new medical plan under the special open enrollment rules, if Mike does not elect to change plans, he will remain enrolled in Kaiser Permanente Northwest 1 because he still lives in Clark County. Are there any questions regarding the proposed policy resolutions?
Any questions for Stella from the
Yes,
board?
I do.
Okay, here we go. Carrie's got a question.
So on Resolution 2023-01 and 02, it's labeled as continuation coverage, but I'm looking at the wording to see if a normal person might think that they're getting more election choices than what I think is intended. So it says whether or not where is it? So they say someone who's enrolled in a medical, dental, or vision plan and is not eligible may elect to enroll in a medical, dental, or vision plan. So maybe I lose, what it sounds like I could do is I lose coverage in a medical plan and I would have a new opportunity to enroll in a dental plan, and I don't think that's what's intended here. Isn't it continuation in the plan? If I had medical coverage, I can continue medical coverage. I can't suddenly add coverage, or maybe I can, I'm not clear. And that's true in 02 as well, the way the wording is. It appears that I would have a whole array of options even if I was only in one kind of plan and lost the coverage there, that I would have options in all 3 kinds of plans. Is that true or not?
Are you tracking the question?
Yeah, well, I think we
Yeah, I think it's, do you get a fresh bite at all the apples when you get through one door?
Because in the others, it's you're continuing the continuation cover. So if it really is that you get, I think we want to be sure that that we're consistent in our interpretation.
Carrie, that's exactly what I was going to say, is these are built off of prior implementation in 2019. So I think what we'll bring back as a response to that question when we bring these back at the next meeting is how it was implemented and whether it was a fresh bite at all 3 of the benefits in a scenario where somebody was only enrolled in a subset of the benefits. But the goal would be to implement in the same way that it was implemented in 2019, which I just don't want us to state it wrong on the record, but
Yeah.
I think the consistency piece is what I would hope for.
And perhaps put wording that
Yes.
makes that clear.
Yep, or an example that also outlines what that is. So
Okay.
that's great feedback.
Nice one, Carrie. That was good.
I do read.
Yeah, I
Maybe you
understood.
should have been here in 2019.
Do we have other questions from board members? No? Stella, thank you so much.
I
Oh.
do wanted to go over the next steps
Oh,
because
I'm
we
sorry.
have
Okay.
a little revision on our next steps.
And as Stella gets there, I do want to highlight one other example, because I realized the 4 examples here didn't actually illustrate this. I had said, plan that the individual could be enrolled in might vary based on factual circumstances. I wanted to give an example of that. So let's say somebody is enrolled in a Kaiser Permanente Washington Sound Choice Plan, which is a subset of Kaiser's service area in the state. They have a larger footprint for their core and PPO plans. If somebody moved out of Kitsap County where they were enrolled in Sound Choice, but moved into a county where there are other Kaiser plans, it may make more sense to enroll them in the most comparable Kaiser plan than over into the Uniform Medical Plan. So just wanted to try and give an illustrative example of why that flexibility might lend to a different result and why it's not so specific in the resolution as to what the plan would be that the individual would be moved to.
So for the next steps, I will prepare the response based on Carrie's question. So thank you. And then we're planning to send out the proposed policy resolutions to our stakeholders for feedback. The plan is to send them out tomorrow, so they will have about 10 calendar days to give us the feedback. And for members of the public who wish to provide feedback regarding the proposed policy resolutions, we have a new email address for collecting feedback. Is HCA PEP SEB board policy feedback at hca.wa.gov. And they can submit feedback by March 13, 2023, so then the staff could adjudicate the comments on time, just in time for the next board meeting on
So
April 6th.
one procedural thing, normally the board sees the resolutions and the resolutions go out, but in this case, to Carrie's point, we might be modifying the resolution and then bringing it back for vote. So how do we want to?
There's actually precedents for that in the past, that there have been questions on other resolutions in the roughly 70 that were passed by the board in the first 3 years, where there were changes that were made to clarify a point that was brought up in the board meeting, and we tried to see if we can incorporate that before it goes out. So Stella has 45 whole extra minutes she didn't expect today. So Stella has her next task already.
She was wondering what she was going to do this afternoon. Now she knows.
So she's going to look into the implementation of 2019-06 and try to align it with that. So there might be a slightly modified version based on the feedback, which is exactly what we're hoping to get by bringing them to the board. Is if there's any modifications that can be made as it goes out in the stakeholder process, we will do that.
And maybe we could send it to the board as well at the same time. We could shoot out the new one. All right.
Thank you very much.
All right. Thank you, Stella. All right, next up, can I ask why we call it hearing instruments and not hearing aids? I know there's probably a technical reason why we do that. I'm just curious.
Because the legislation is all about hearing instruments, and so we've just gotten used to saying hearing instruments because House Bill 122 that we all talk about uses that phrase.
Got it. Okay. Next agenda item, hearing instruments overview. Sarah Whitley, fiscal analyst from Financial Services, can provide an introductory overview on hearing instruments. Materials are behind tab number 8. Hey, Sarah.
Hey, Chair McDermott and members of the board. My name is Sarah Whitley, for the record. I am the Employee and Retiree Benefits Finance Unit Manager here at HCA. And you often see our finance team presenting rates or budget updates, but another really important aspect of our role here is using our plan claims experience, especially for UMP, to identify areas of possible opportunity, which is what brings me here today with you. We believe we have identified a possible opportunity for more effective plan management related to...
Excuse me for a second, not to be funny, but Sarah, could you get a little closer to the mic? I'm having a hard time hearing you.
Sure, I'm not a very loud person, so I thank you for mentioning that.
Actually, that was pretty funny, and we liked it.
Appreciate it. Yeah, so let's move right on in here. So next slide. So I'll start with an overview of how the hearing instrument or hearing aid benefit is covered in SEB today. So this slide includes a summary of the current benefit design for hearing instruments and routine annual hearing exams in the SEB program. And you'll note, while there's some variation in member cost sharing related to the annual exam itself by carrier and by plan, the common thread across all of our carriers and plan offerings is that all plans offer coverage of hearing instruments at a $0 member cost share every 5 years. While this is the current benefit design, historically coverage levels have looked a little bit different, especially in our self-insured UMP plan offerings, and that'll be the focus of our conversation today. Next slide. Prior to plan year 2021, the UMP hearing allowance for hearing instruments was a total of $800 every 3 years for either 1 or 2 hearing instruments. Said a different way, that means that a member was provided reimbursement for up to $800 for hearing instruments every 3 years. Any cost incurred above that $800 threshold were members' out-of-pocket responsibility. Based on what we know about the average cost of a hearing instrument, prior to 2021, most members obtaining these hearing aids were paying significant amounts out of pocket, suggesting that that $800 coverage limit was not set at a sufficient level. During the 2017-2018 legislative session, Senate Bill 5179 passed and required coverage of hearing instruments every 5 years for PEB and SEB employees and dependents. This legislation resulted in the current benefit levels that you saw here on that first slide for hearing aids in both UMP and all of our other plan offerings, which effectively provide coverage at $0 member cost share for 1 instrument per ear, so up to 2 ears, every 5 years.
This is Dave. One other piece of context is Senate Bill 5179, just looking at the commercial insurance market in our state, not other coverage, only for the commercial market only applied to PEB and SEB. That bill did not apply to the general commercial insurance market in our state. I want to contrast that with the bill that's going through the legislature right now, House Bill 1222, which does apply not only to PEB and SEB, but also the entire commercial market in our state. So just one other piece of context. I can't help myself.
Thanks, Dave. So moving into the next slide here. While the effective date of the legislation passed under Senate Bill 5179 was January 1st, 2019, implementation of the mandate was subject to budget appropriation, which wasn't included for PEB and SEB until the 2020 supplemental budget. That 2020 supplemental budget included adequate funding based on our initial cost projections for this legislation for a 2021 plan year implementation date. Leading up to implementation for the 2021 plan year, Regents, our TPA for the Uniform Medical Plan, engaged us regarding a handful of network concerns, including limited access to hearing instrument providers, especially on the eastern side of the state. There were concerns that network waivers would be required for members seeking care in areas with limited access. Along with that limited network of providers, Regents was unable to operationalize a specific allowed amount for the Uniform Medical Plan. And so a decision was made that billed charges would be paid in lieu of an allowed amount for all hearing instrument claims to ensure that our members received adequate and timely access to these services. As a quick reminder, I did want to pause here and define the difference between an allowed amount and a billed amount for those of us that aren't in this world every day like I am. When we talk about allowed amounts, that's the amount that typically represents the maximum amount a plan will pay for a service performed by a provider, and it's usually a negotiated dollar amount between a provider and a health plan. A billed amount is typically the full cost of a service as billed by a provider. It's not tied to any negotiated or contracted rate and are oftentimes higher dollar amounts than what an allowed amount would be. Next slide here. So following implementation in UMP, we've taken a deep dive into the UMP claims experience, and that coupled with some of the background context related to how this benefit change was implemented in UMP, we've identified 3 key areas of focus for our conversation today. The first is induced utilization following implementation of a fully covered benefit in UMP. As coverage levels increased, utilization of these services also increased significantly, as to be expected. This is likely because the benefit limit of $800 prior to 2021, again, was not at a level to provide sufficient coverage for hearing instruments without members paying significant amounts out of pocket. Once coverage levels changed to provide full coverage of the hearing aid every 5 years at a $0 cost share to members, utilization of these services increased by more than 300% beyond our original projections for what we thought would change following 2021 implementation. This indicates at least some level of suppressed demand for hearing aids prior to the benefit change in 2021. The second is the payment of billed charges in UMP, coupled with that significant increase in utilization, has led to significant increases in unit cost in UMP, which are more than double what was originally projected for this benefit prior to 2021, and you'll see that in greater detail here in the next few slides. And finally, because UMP is paying bill charges for hearing aids, there's no incentive for members or providers to avoid those excessive cost options that are out on the market. So based on our market research, the cost and types of hearing aids available for members can vary significantly. It was actually quite shocking to me, the number of hearing aids that are on the market and the types available. A standard offering generally costs between $1,500 and $2,500. Again, a lot of variation there. Where a more high-end model with some bells and whistles that might not necessarily be medically necessary can cost significantly more. Since 2021, we've seen claims for hearing instruments paid as high as $16,000 for a single member, just as a quick anecdote there to show how varying the cost for hearing aids can be. Without an incentive to seek out those more cost-efficient but still medically effective options, UMP will continue to pay for these more expensive and, again, not necessarily medically essential hearing instruments. So as we move into our next handful of slides here, this brings us to some of the data that supports our findings. So as noted on our previous slide, utilization and unit costs have been identified as two key drivers in UMP for our conversation today. To orient you to this slide here, on the left-hand side of the screen, we have a summary of total unit counts by plan year for both the PEB and SEB populations. PEB Medicare is that lime green bar, PEB non-Medicare is the bright blue bar, and then SEB is represented by that gray blue bar there that you see pop up right in 2020 when we implemented the SEB program. So while we're here today focusing on our SEB members, we've included PEB to help provide context for what levels of utilization and cost prior to SEB's inception in 2020 looked like. And you'll note here, it's pretty obvious, prior to 2021, UMP experienced pretty modest utilization of hearing instrument benefits with around 2,000 units per plan year. And then during the 2021 plan year, we see more than a 300% increase, so that bright green bar kind of jumps way up there. With most of that increase appearing in our PEB Medicare risk pool. But still we see significant increases for SEB when we look at 2020 versus 2021. I do want to quickly note here, I've included 2022 preliminary claims information on this slide here. That data only includes claims incurred and paid through September of the 2022 plan year, so it's not a full look at the experience. It might look like we're seeing utilization return to pre-2021 levels. However, based on what we've seen incurred through those first 3 quarters, we're likely to see utilization levels at least sustained and increased trend similar to what we saw in 2021. It might not meet that same level, but I think we'll see a similar increase. On the right-hand side of this slide, I've included a table with the average UMP paid amounts per distinct member who received a hearing instrument in each plan year. So again, you'll notice a very obvious swing in the plan paid amounts from 2020 to 2021, with amounts prior to 2021 coming in right around that $800 benefit limit. And then once 2021 plan year data shows up on the screen there, you'll see that jump to about $6,000 paid per distinct member. Our next slide is just another view of that table that we just reviewed together, this time in a bar graph rather than a table. And we can clearly see again that stark increase in plan paid amounts following implementation of the benefit change in 2021. Again, the majority of that increase we see in the Medicare population, where we're also seeing higher levels of utilization as well. And this is to be expected as members age and require assisted listening devices. We do see that significant increase, however, again, across both of our programs and risk pools, indicating there's an opportunity for cost containment efforts across all of UMP. So our next slide here provides a little bit more of a granular level breakdown of UMP paid amounts, this time by a cost range, which are listed there on the left-hand side of the axis of this graph. Again, each bar here represents the program and risk pool and provides a count of distinct members there on the very end of the bar on the right-hand side there, with a claim for hearing instruments that fell within that cost range during the 2021 plan year. And what I find most interesting about this slide is really the significant amount of variation in UMP paid amounts by cost bucket. So there's really no way to look at the graph and say, oh, the majority of our claims are paid in this bucket. There's so much variation in the amounts that are paid, from a lower range of between $0 to $4,000 per member claim to anything greater than $9,000. So finally here, if we move to our next slide, in our last look at the data, this slide features a summary of Plan Year 2021 highlights. So members can receive, as we've mentioned, 1 or 2 hearing aids every 5 years based on their needs under the current coverage benefit. One of our very first questions when digging into the data was, well, how many hearing aids do members typically receive? And overwhelmingly, our members are receiving 2 hearing aids, which is about 83% of our claims in 2021. And then again here on the right-hand side of the slide, we have our average paid per distinct member coming in right about $6,000, indicating that because our members are receiving on average 2 hearing aids at a higher rate than 1 hearing aid, UMP is paying about $3,000 per hearing aid for our members.
This is Dave. One just correction on the slide. The legend shows purple as 2 hearing aids, but the pie wedge is actually green. So green and purple are the same on this slide.
Yes, thank you, Dave. Purple and green, not the same color. Appreciate the clarification. Okay, so our final slide today, given what we've covered here and the insights gleaned from the data and the analytics, the main takeaway from our presentation is that unlimited coverage resulting from Senate Bill 5179 and how it was implemented in UMP has led to some unanticipated levels of healthcare spend for hearing instruments. And as a self-insured plan offering, UMP premiums are set and are based on the total projected amounts required to cover all benefits provided to members. And as healthcare cost liability increases, upward pressure is placed on member premiums. And so we believe we've identified an opportunity here to maybe adjust our purchasing strategy in UMP that could place downward pressure on premiums for members in both the PEB and SEB programs. So today's presentation was intended to really set the foundation for a future discussion. We're currently exploring what a few proposed solutions could look like, which I'll bring with me to our next board meeting in April. And there's been some renewed focus, as Dave and Kate had mentioned, during this year's legislative session on hearing instrument coverage. House Bill 1222 addresses hearing aid coverage, and we're keeping an eye on how that bill progresses in the coming weeks, with hopefully more information next month when I join you again. Dave, anything to add or any questions?
There are two things I want to add. The first is just, Sarah, do you remember the context of Senate Bill 5179, roughly the fiscal estimate? I believe it was somewhere in the $1 to $2 million range overall. And Sarah's nodding yes for everyone, that the fiscal note, when we did our original projections, thought that we would see an increase in expenditure in UMP in the PEB program, because SEB didn't exist yet, of about $1 to $2 million. But if you go back to slide 7, we don't need to go back there for purposes of the team here, you'll see that we actually spent over $30 million in 2021 in a single year. So that is quite a difference for the various reasons that Sarah highlighted in pent-up demand, the various parts of her presentation she described. That is quite a big difference from our original fiscal note projection, from what was actually being experienced. And even in the partial 2022 data, we're seeing that within the PEB program, we spent so far $8.6 million. Again, a substantial difference from what was in the original projections of the original bill. So it's one of those things that this is an example of the work that happens every year in UMP and the fiscal team looking at things. The other piece that I want to highlight is this isn't the first time that something like this has happened. After the ACA passed and pediatric vision hardware was required in plans, this similar phenomenon happened where high-end glasses or hardware and frames were being procured or selected by those who had access to 100% covered hardware benefits. And so we saw a lot of variation in the hardware that was being selected, some of which was not medically necessary. It included name designer brands, for example, but the coverage was 100% of coverage, and so those were covered for a period of time. And the industry responded by focusing on benefit limits or allowed amounts to make sure that there was adequate coverage to ensure medically necessary hardware was achieved and received without non-medically necessary aspects of those frames being covered. And so it's a similar phenomenon that is kind of playing out in the hearing instrument world. And so just wanted to give that as a compare and contrast of something that as soon as we saw this data, most of the team went, this is pediatric vision hardware, take two. So just wanted to highlight that for folks as well.
Who doesn't love Gucci and Versace? They're nice. Question, was there something at the federal level also occurring related to hearing instruments? There was some sort of, I don't know if it was deregulation, but sort of opening it up to the non-medical space, so like Apple could come up with something. Was there anything like that happening?
Yes, and we can bring that back in April as well, but some of the policy changes that happened, believe it was last fall, made over-the-counter hearing aids for not all instances of hearing loss, but I believe there's a definition of minor hearing loss, opening up access for over-the-counter hearing aids and allowing more market competition and access to hearing aids outside of traditional insurance models. But it's not for all levels of hearing loss. So we'll bring some more information about that, but there was a change in federal access to over-the-counter hearing aids.
Would that be something that would be covered by insurance if you go and decide to purchase something over the counter, but you do have a prescription from an audiologist?
Well, so that is, the over-the-counter piece doesn't require a prescription, but we'll dovetail that into April as well.
Okay.
We'll do a dive into the federal change on OTCs.
Appreciate it. Do we have questions or comments from the board? Any hands up? Gary? All right. Stella, thank you so much. Appreciate it.
Sarah?
Oh, Sarah. I'm
That's
sorry.
okay. That's all
I'm
right.
sorry.
Thank you.
Yeah. Dang it. I was having a good day too, and then pride myself on trying to not screw that up. All right. It's time for call for public comment. If anyone on Zoom that would like to provide comment, please raise your Zoom hand. We're going to gather a list of speakers so we can manage the time allowed for public comment. If you're virtual, again, please click the virtual hand if you'd like to speak. If there's anyone in the room from the public that would like to speak, and I don't see anyone from the public in the room. So do we have a list? Nothing? We'll give it a little bit of time for people to find their Zoom hand. All right, no public comment at this time. Our next meeting is scheduled for April 6th from 9 to 1:30 with the same format of attendance in person or via Zoom. Dave, any final comments before we adjourn?
No, just by the time we come back in April at our next meeting, we will have legislative budgets from the chambers as anticipated. So we will hopefully have Tanya here to describe what the budgets look like in comparison to the governor's budget. We'll have that financial presentation, hopefully without a personal emergency. We always like to support our staff, and the next stage and context about the hearing instruments.
All right, thank you. And I just want to thank staff for, these hybrid meetings. I've been to a few where it was the agency's sort of first crack at it, and they were pretty bad. And so really appreciate all the work. It's not as easy as it looks. I appreciate all the work that's going into making these meetings smooth. So thank you so much. Much appreciated. I guess this meeting is adjourned. Thank you all. Travel safe. Have a good day.